Thank you, everyone. We will begin in 1 minute. Good evening, everyone. My name is Tina LeMay, Manager of Patient Services at Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate today's webinar and to learn more from our guest speaker, Louise Forest-Lalande. I'd like to start by welcoming everyone to the webinar and then outlining today's agenda. Today's education webinar is called Ostomy 101, Everything You Need to Know About Ostomies and Pelvic Pouches, and it's hosted by Crohn's and Colitis Canada. For those new to webinars, I will quickly run through how it works and how to ask questions. As you will notice, currently all participants are muted so that everyone can hear the presentation and we can capture this webinar recording without audio interference. If you'd like to ask questions at any point during the webinar, simply write your questions in the questions field box on the right-hand side of your screen. You can enter your question at any time during the presentation and we will make note of them to be addressed at the end of the presentation. We have allocated around 10 to 15 minutes for Q&A. If you're having trouble hearing the speakers, it may be due to your personal audio settings. Either turn up your volume on your computer, mobile device, or trying to call in with the phone number provided when you logged in and then enter the code when prompted. Great. Now for a brief intro about Crohn's and Colitis Canada. Crohn's and Colitis Canada is the only national volunteer-based charity in Canada focused in finding the cures for Crohn's disease and ulcerative colitis and improving the lives of children and adults affected by these diseases. We are one of the top 2 health charity funders of Crohn's and colitis research in the world, investing millions of dollars in research since 1974. Our investment has led to important breakthroughs in genetics, gut microbes, inflammation, and cell repair, as well as laying the groundwork for new and better treatments. We are transforming the lives of people affected by Crohn's and colitis by supporting research, delivering education and patient programs, advocating for those affected by these diseases, and spreading awareness. If you'd like more information, please visit our website at www.crohnsandcolitis.ca. I'm now pleased to introduce to you our guest speaker, Louise Forest-Lalande. Please, Louise, correct me if I mispronounced your name.
Okay.
Louise worked at the CHU St. Justine as an enterostomal therapy nurse, also known as ET nurse, from 1995 to 2011. In 1992, she completed a master's degree at the University of Montreal in adult education. She is a lecturer at the University of Montreal and several universities and hospitals in China. She has published many papers on pediatric ET nursing and presented on her specialty in many countries. She has served on regional, national, and international boards, including holding the role of President of the World Council of Enterostomal Therapists from June 2010 to June 2014. Louise also collaborates with the wound care and enterostomal therapy nursing organizations. She's presently writing a book about pediatric ET nursing. Thank you very much, Louise, for being here today. We're so excited to learn more about ostomies and pelvic pouches for IBD. Please take it away.
Thank you, Tina, and thank you also for the Crohn's and Colitis Canada organization to invite me to share my knowledge with you. So we will start first by the agenda. Not sure if I can get my slide. I'll try again. Yeah. So first of all, I would like to introduce you to the role of the enterostomal therapy nurse. And we will talk about what is an ostomy, what is it living with an ostomy, and how can we manage the ostomy when we have one. And I will also discuss some resources that can help people with an ostomy. It will be about professional, financial, or psychosocial resources. So first of all, what is an enterostomal therapy nurse? She is a registered nurse with a bachelor degree who has complete additional training in ostomy, wound, and continence care. So she has a basic training as a nurse, but in Canada we complete a training that is offered by the Canadian Association of Enterostomal Therapy Nurse, and it takes 1 year and a half at least to complete the training. The ET nurse, let's call her the ET nurse, is working closely with the surgeon. It is really a teamwork. Surgeon is doing the surgery, but the ET nurse is there also to help the patient, to prepare him and to support the patient to adjust to the life with an ostomy. And also, in case of any complication, she knows, first of all, how to prevent them and then how to manage the complication. So, yes, as in my introduction, I have been working with children all my life, and I was working as an enterostomal therapy nurse with children. So when I tell the people, oh, I'm working, with children. They say, oh, it's so sad. How can you work with children with ostomies? And I always show them this slide. So this is me with a baby who was born with cancer of the bladder. So this is me, but many, many years ago. And then this is me with the same guy 17 years later. He came back to the hospital to have a closure of his ostomy. And now he has no ostomy. So for me, working with children as an ET nurse, it gives me the joy to see my patient growing up and also heal. So now I will talk about something more, not difficult, but more dry. The topic is more dry because it is about anatomy and physiology, but I just want to do a recap of the digestive system. So we have we take our food by mouth, and then it goes into the stomach, and then it goes into the small bowel, and then it is mixed there and with the enzymes, digestive enzymes, and then the stool will go through the large bowel, and in the large bowel it's the water that will be reabsorbed, and then we can expel the stools by the rectum and the anus. So what is an ostomy? An ostomy is a surgically created opening of the bowel or of the urinary tract on the abdomen. So this is an ostomy. This is the abdomen, and this is the ostomy. So it is an opening of the bowel, and it is a mucosa. It is pink to red. It is shiny because it is a mucosa. It is like the inside of our mouth, and it is insensible to touch. So because there's no nerve endings on the ostomy. So when we touch the ostomy, we don't feel anything. Because it's like when we go to the dentist and that we have local anesthesia. So we can feel that we touch the ostomy, but it doesn't hurt. The ostomy is highly vascularized, and this is why if we rub the ostomy when we do some caring of the ostomy, so if it is rubbed, then it can bleed a little, but this is not a problem. It is not a complication. It is normal, so we must be very careful. although we don't feel it, we can have it bleed easily. The ostomy can have varied shapes. Can be round or it can be oval, and I will show you more picture about that. And the protrusion is variable. The height of the ostomy is variable, and but this also I will show you some pictures that will explain better what I want to say. So when we have an ostomy on the small bowel, the name is ileostomy. And when it is on the large bowel, it is a colostomy. So ileostomy first. Usually the ileostomy is located at the right side. And the stools that will come from the ileostomy are liquid to pasty stools because the water has not been absorbed yet, because as I told you before, it will be reabsorbed in the large bowel. So in the ileostomy, stools are liquid to pasty. And the transit is fast. So this is why for the people having an ileostomy, they must be careful. You know, when they eat, it won't take long since they pass stools. And also it is important to tell the pharmacist that you have an ileostomy, because some medication are coated with products that will be digested only in the large bowel. So just to show you, when the surgeon is making the ileostomy is protruded maybe from 2 to 3 centimeters on the abdomen, and this is a picture of an ileostomy. And it is important that it is protruded, because since the stools will be liquid, we don't, or pasty, we don't want them to go on the skin and digest the skin. Then the colostomy. The sites are variable. It can be on the ascending colon, on the transverse, or at the end of the colon, depending on the disease. And the consistency of the stool varies from the location. So if it is at the beginning of the large bowel, they will be liquid. The more we will advance in the bowel, the more pasty and like a normal solid they will come. So, and some people who have a colostomy at this part of the bowel, of the large bowel, may have the same elimination pattern as they had before. And this is to show how it is constructed. So as you can see, since the stools will be more solid, then the height of the ostomy does not need to be so protruded. And this is a colostomy. The pelvic pouch is something different. It is a surgically constructed reservoir made with a part of the small bowel after the resection of the large bowel. So the people having ulcerative colitis, it is only the large bowel that is sick. So the doctor will remove just, now there's no more, but no more large bowel, but he will remove the large bowel, and then after some time with the small bowel, he will create a reservoir. This one has a J form, but it can be in S or W. It depends on the surgeon. And with this, after a while, after a few weeks, because some surgeons, they create a temporary ostomy for a few weeks before reconnecting all the digestive system to the anus. So let's say that the patient may have a temporary ostomy for maybe 3, 4, 5 weeks, and then the surgeon will reconnect the pelvic pouch to the anus. and then the patient will be able to pass stools normally, the same as he was before. So why are some ostomy permanent and others temporary? Surgeons will do temporary ostomy when there is a need to put a part of the bowel to rest, or in some situation it is until the patient's health condition has improved, or if the rectum is still in place, because to be able to recognize the digestive system to the anus, the rectum must still be in place. So it can be after a trauma, after a pelvic pouch reconstruction. So in this case, it will be a temporary ostomy that can last for a few weeks to a few months, sometimes a few years. And we will do a temporary ostomy to protect an ilioanal anastomosis or pelvic pouch. On the other hand, where the surgeon will create a permanent ostomy when there is no possibility to recognize the bowel, or if the rectum has been removed, then there's no more possibility to recognize the digestive system. So when we plan for surgery for an ostomy, it is very important to decide where the ostomy will be located on the abdomen of the patient. And this is usually made by the ET nurse or by the surgeon. So it is important to examine the patient in sitting, lying, standing, and bending position to make sure that where we will put the collecting device, there will be a proper fitting of this collecting device. So we want to make sure that we want to avoid any folds, skin folds, any creases, any scars, or bony prominences. The patient must be comfortable with the location of the ostomy. He must be able to see it, and we must make sure that there is a plain surface, plain area all around the ostomy to make sure that the adhesive wafer will stick well, will adhere well to the skin. But this, I will show you appliance later on. So, and also it is important when we locate the ostomy that it is in the rectus muscle, because the rectus muscle, you know, these six packs that we all want to have, they are more resistant. So if the ostomy is in the rectus muscle, then there will be less complication like hernia. So it will assure that the ostomy in the inside of the abdomen is well maintained. And also, as I said before, it is important that the ostomy is visible to the patient. So in the case of patients who would have a big abdomen, we cannot put the ostomy under, you know, in an area where they cannot see it, because they must care for the ostomy. So we want it to be visible to the patient. And again, the goal is to assure a proper fitting of the collecting device. So this is just to show you where we can do the ostomy. So these are the rectus muscle, okay? And it can be, this is the umbilicus, so it can be to the right or to the left of the patient, and it can be, in case of transverse ostomy, on the transverse large bowel, it can be up. But the important is that it is away from bony prominence and skin fold. So in this, this is a bulb. It should be in this area and not where under where the patient cannot see it. So it should, usually it is in between the right trochanter and the umbilicus in the middle, okay? But the ET nurse has all the knowledge and competency to do that. And it is easier for that because she can spend more time with the patient and see him in different positions. When the surgeon sees the patient on the operating table, you know, the patient is lying on his back, so there's no skin fold or less skin fold. So this is why we do it before. And we will mark the site with a product that is indelible, so that the surgeon, when the patient arrives at the operating room, we can still see where is the mark. So is the ostomy visible to others? Usually not, okay? So there's no need to change one's wardrobe. People can wear the same clothes that they were wearing before. But the patient will wear a pouch, and the pouch, we must understand that it will become bigger if there is a need to evacuate gas or if it is filled with stools. So this is the only time where the pouch will become bigger. But also nowadays, pouching systems are designed to be discreet. So we want them to be as thin as possible, and they are also odor-proof. So how about the elimination? When we have an ostomy, there's no more sphincter controlling the elimination. The sphincter is, when we want to when we want to wait a little before going to the bathroom, we can, contract they are like circle muscles around close to the anus. But when people have an ostomy, there's no more sphincter. So the elimination, there's no control on the elimination. So in the case of ileostomy, the stool will come out on its own, and patient will not feel the need to evacuate or that they are passing stool. And when we have an ileostomy, it is especially after a meal that this will happen, sometimes 30 minutes or maybe earlier after a meal, usually. When people have a colostomy, it depends on the location on the large bowel, as I has explained before. So some patients may resume a similar elimination pattern as before the surgery. About the nutrition, most people can eat the same as before. It is, however, recommended to avoid food that can increase gas because, as I said before, the pouch, the collecting device will become bigger. So we avoid these kind of food. And when a patient has a new ostomy, then what we recommend is that he introduce just one new food at a time. So when doing that, you can be sure you can identify to which product how you react to specific products. Okay, some of my patients, they had an ileostomy, and when they wanted to have pasty stools, then they would eat a pizza. But this is not for everyone, because usually when you eat a pizza, because of the spices, you will have more liquid stools. So this, we have general basic principle and general principles, but this will depend on each patient. It can be different. So this is why you introduce just one new food at a time. Patients with ileostomies, it is very important that they chew very well their food, because what we eat in our nutrition, like the fibers, like in a celery, all the fibers in the celery, this is not really digested by the digestive system. So or I will give another example. Peanuts, if peanuts are not chewed very well, then they can create kind of plug that will block the ileostomy, because as I said before, the ileostomy is in the small intestine, so the lumen of the intestine is not that big and it can block easily. So this is why it is important to chew very well. A patient with an ileostomy who is eating a raw carrot, if he does not chew them very well, he will find piece of carrot in his pouch. So again, we people with ileostomy, they must chew very well. Also avoid fibrous products, as I said before. Drink a lot of water to compensate for water loss, because as I said also before, the water is reabsorbed in the large bowel. So people with an ileostomy, they don't have anymore their large bowel most of the time, so they cannot reabsorb the water. So to compensate for this loss of water, they must drink a lot of water in a day. The people with colostomies must be aware of constipation, because it is not because you have an ostomy and that you have no sphincter that you cannot develop constipation. And so this is something that they must think about, if they, because usually they will pass stool once or twice a day, but if they don't pass stool for 2 days, then it may be a sign that they are constipated. So they must be aware that they can, even though they have an ostomy, they can get constipated. The skin around the ostomy. This is extremely important. The skin surrounding the ostomy must always remain intact. It must be healthy, as the same as on the other side of the abdomen, okay? Because it is on this skin that we will put the skin barrier, okay? So if we want the skin barrier to adhere well to the skin, it is very important that the skin is intact. It is healthy, because if the skin is weepy, if it is irritated or with some leakage, then it will be difficult to make the skin barrier adhering well. And the skin barrier must be cut to the size of the ostomy, but this I have other pictures to show you. So we cut it to the size of the ostomy with just 3 to 4 more extra millimeters, because the ostomy is alive, so it can move. If the stool are advancing in our bowel, it is because we have peristaltism, that we say. It is movement from the bowel, contraction of the bowel, that will make the stool going through to the rectum. But when we have an ostomy, then the bowel can also move a little because of these movements. So this is why we don't want to cut too little, because we don't want to hurt the ostomy. So, and for the patient having a new ostomy, the size of the ostomy must be measured at each change of appliance, at least for 4 to 6 weeks after the surgery. Because what is happening right after the surgery, the bowel has been manipulated by the surgeon, and the bowel is swollen. Okay, so and by the time that the edema, the swelling diminishes, it can take up to 4 to 6 weeks. So this means that at the beginning, the ostomy may look quite big, but it will reduce in size during the following weeks. So this is just to show you in 1940. This is an appliance from this time, and it was probably surely very, very uncomfortable. It is made of plastic, of leather, and I just put this picture not to afraid people, but just to let you know how different it is today, how improvement has been done, and this is thanks to the help and the support of people with an ostomy, person with an ostomy, manufacturers, ET nurses. So, and it is still improving over time. Just want to, I think, yes. These are the new appliances. As you can see, they have nothing to do in comparison to what it was before. So we can have, this one is a one piece for a urinary ostomy, okay? And these are what we call two pieces. So this is the skin barrier that will protect the skin around the ostomy, and this is the pouch that will be clipped on the skin barrier. It's like a Tupperware, if you want an example. So this is a two-piece, and this is just to show you I was working with children and babies and premature neonates. So this is the smallest pouch I never saw. It is very, very small. So the ostomy products are now designed to be discreet, and they are odor-proof, and also some accessories are available like paste or belts. But this is something that if you need to know more one day, you know, the ET can give you more information about it. So just to illustrate what I was saying before, cutting of the skin barrier. So this is the skin barrier that will go on the skin. And sorry, design is not my best, but this is an ostomy. And we have to cut this skin barrier, okay, to the size of the ostomy plus 3 to 4 millimeters. And this is what it should look like when it is cut. Okay, this is the ostomy that is protected, and then when the stool will come out from the ostomy, then they will go on the skin barrier and they will digest the skin barrier. But if there is no skin barrier, then they will digest the skin. And this is when the skin will become red and painful, and this is what we don't want to have. So we want to protect the skin by putting a skin barrier around it. So the management of the pouching system, the pouch should be emptied when it is 1/3 full. First, it's because it can be uncomfortable. It will look bigger under the clothes, and also it will make a kind of, it will produce a kind of weight that will tear the pouch, the collecting device. So it is important to empty it when it is 1/3 full. And there's no need, however, to clean inside the pouch because if you clean it, okay, first of all, you can interfere with the odor-proof product that is on the plastic. And also, after a few minutes, when you put it back, then the stools will come out and it will be soiled again. So there's some way to clean at when we empty the pouch, but again, the ET nurse can teach you how to do it. And so usually a patient with an ileostomy will have to empty his pouch maybe 5 to 6 times a day, while a person with a colostomy may empty it only once a day. The pouching system, all the skin barrier and the pouch are usually changed every 5 to 7 days, depending on the type of the ostomy. Sometimes with ileostomy, there are more enzyme in the stool because stool because they are liquid, so more enzymes are present and may affect, the skin barrier. So depending, but usually, let's say that it is between 5 and 7 days. We should also change the pouching system when there is a leakage of stools or odor, or when the skin is itchy, burning. This may mean that there's no more enough protection around the ostomy. Usually with good hygiene, there's no odor, and but I just want to let you know that specialized deodorants are available, but again, your ET nurse can give you some tips. We can have commercial deodorants, as we can also have other products that can be used to as a deodorant. Bath and shower, is it possible when we have an ostomy? Yes, it is, and you can take your shower or your bath with or without pouching system. Of course, if you have an ileostomy, you choose a time of the day when the ostomy activity is calm. So it may be before breakfast or 2 to 3 hours after a meal. And sometimes people are afraid that the water will go into the ostomy, but no, it cannot go into the ostomy, so there's no problem. Activities of daily living can be resumed according to what surgeons agree to, and but usually, when after a few weeks, young people can go back to school, older adult people can go back to work, they can go back to their social activities, they can play sports. What we usually say is that they should not play, games where there are too rough contact. But again, there's always a way to protect the ostomy when doing sports. And you can also travel and also resume sexual activity. Just a few words about potential complication, and most of the complications are related to the skin that is surrounding the ostomy. So this is why, as I told you before, it is important that it remains intact, healthy. And another problem that can happen is the leakage following an inadequate fitting of the pouching system. So, all of us, we have different abdomen. Some abdomen are firm or are softer. So there's a way to manage that, and the ET nurse can help you finding a solution if needed. For the Psychosocial Resource, you have Ostomates Association. So we have regional, national, and international Ostomy Association. In Canada, we have Crohn and Colitis Canada. And also in Canada, we have an Ostomy Youth Camp. And this is a picture that was taken last year. I used to go as a volunteer to the youth camp, and since it is sometimes more difficult for kids, to go to Ostomates Association because the age of the people are not their age, but during 1 week we have a camp. It is in Alberta. And the kids are coming from Canada, from coast to coast, and it is a bilingual youth camp. And for 1 week, they can meet other kids having an ostomy, also having other problems, having not other, but the same problem as they experience. And this is exactly how I met people from Crohn's and Colitis, because we were sharing the same nurse station last summer. So this is a good opportunity for teenagers. and kids it is from 8 to 17 years of age, and for 1 week they can share their experience and feel also that they are not alone, so it can break the isolation they can experience. Uh, who is paying for the ostomy products? So this is, in Canada, depends where you live. First of all, if you have private insurance, uh, some insurance will pay 60%, others 80, or even 100%. So people must have their own insurance company. And according to the province or territory you are living, you can have a provincial reimbursement program, social welfare, or for children, there is a possibility of additional family allowances. And for the professional resources, the gastroenterologist or the surgeon are your medical resources, and the ET nurse is also a very good resource for the patient with an ostomy. We have a Canadian association, and here you can see the website. So if you live in an area where you want to know if there is an ET nurse, you can contact them and they will help you finding a place. And we also have an association in Quebec. Additional resource would be the manufacturers, the people who are, producing these ostomy products. So you can get in touch with them. You can ask them for samples, or you can ask them also if you have any problem with any problem related to the manufacturing of the product. We have retailers, depending on the province. We have some retailers in the province of Quebec, but in Quebec it is also the pharmacists who are selling the products for ostomy. So again, depending where you live in Canada, you have access to these resources. And I think that this was my last slide. So I hope that I succeeded to have you learn more about what is an ostomy, and that if you have any question, it will be my pleasure to answer them.
Oh, thank you so much, Louise. That was definitely an informative session. We will now get to the participant questions. One question: how do men manage the hair on their torso under the flange? Can they wax it off?
We don't recommend it to cut it too close. We prefer to recommend that they use scissors. Okay, because if it is important that they don't develop any infection of the hair follicle. So if they wax it, they can produce a kind of trauma, and then they may develop some irritation. But usually we don't. This is not what we recommend. We recommend that they use scissors, and that they cut the hair not too, but close to the skin. And what is very, very important also for men is that when they take off the skin barrier, they should go gently. They don't want to tear the skin, and to be. It must be done gently.
Well, thank you very much. Can you swim with an ileostomy bag?
Of course you can swim, you can do what you want with an ostomy bag, but you know what, first of all, if there's some pouches are smaller than others, okay? So for swimming, let's say, or for when having sexual intercourse, then we can use a smaller pouch, okay? What is also very important is that before any sportive or sexual activity, it is important to empty the pouch, okay, to make sure that it is empty. And then you can put a smaller pouch, but not for a long time if you have an ileostomy, depending on the time of the day. But you can swim, And the e-Nurse can give you some good tips also. Me, I was working with children, and I recommend them to put a liquid film barrier over the ostomy, not on the skin, over the skin barrier to make it waterproof.
Oh,
And no problem, they can swim. I would like to take this opportunity also to say that for some sports, maybe it would be preferable to wear a belt. But again, this is the ET nurse who can recommend you what kind of belt, and it is a ostomy belt, and it is important to know how to wear it at what level on the abdomen.
oh, that's a good tip. Um, in terms of ostomy replacement, how long does an ostomy last?
Oh, it can last for years, if not for life, you know. Again, me was working with children. Some kids had their ostomy when they were 5, 6 years of age, and they had the revision maybe when they were over 20 because their body was changing. But most of the time, you know, the body will grow up, you know, how can I say it? You know, in a fashion that everything is well in place. Oh, I don't know. I cannot express it correctly. You know, it will be harmonious the way
Okay.
okay. But for some reason, you know, if patient may develop problems that will um, will ask them to that will require that the ostomy is repositioned, but this is not usual. Usually people, they can have the same ostomy for years if they don't have any problem.
Right. That's good to know. So with an ileostomy, can you hear the stool when it leaves the body and goes into the ostomy bag? Does it make noises?
It can make noise, yes, it can make noises, and especially during the following weeks after the surgery. Okay, but of course, depending of what you have been eating, it can produce gas. You know, when we don't have an ostomy and that we have gas, we know that we can retain our gas, but sometimes when we cannot, you know, this makes noise. So with an ostomy, it will make noise, yes. So this is why when you plan to go to the theater, let's say, then you try avoiding products that will create gas.
Very good. That's good to know. So another question, how is constipation managed in the colostomy patient?
Oh, first of all, we ask them to drink more water, and also they can introduce more fibers into their nutrition, their diet. So more fibers, and also they can have a laxative if needed sometimes, but this I would ask the ET nurse or the surgeon before. But they can, some of them, depending on the person, you know, they may have to get some laxative or a small enema, but this is uh, according to doctor's order.
Okay.
But the
So
diet is the best.
that's good to, yes. Um, in terms of, what do you think, based on your experience, what has been the biggest struggle for your patients who have a new ostomy?
I think that at the beginning is to get used to it because it is, you know, it is an adjustment, and I think that the patient must, you know, at the beginning they are in shock
Right.
and they think that they won't be able to learn how to care for it and that it is complicated. but over time, step by step, they will get used to it. What I think is very, very important is if they can have the opportunity to meet another person with an ostomy before the surgery or after the surgery, but to see how another person can live with an ostomy and all that what they can do with an ostomy. So, but I think it's a question of time. The struggle is that we live, I think, in a time where we want everything going fast. Okay, but this, you must let your body getting adjusted to it, not only your body, but your mind, your soul.
Very good. In terms of traveling, do you need some ID card when traveling over
Yep.
borders, like going through security?
Yep. And this you can ask your ET nurse. There's some cards, and also I know that Ostomy Association, they can provide you a card where it will be written what kind of pathology you have, and that you must have an ostomy, and this is why you carry with you some appliance, and also when you go through the scanner, it will beep for sure. So it is giving some explanations about what is an ostomy, and you can have also the doctor's or the ET nurse signature on it. And when traveling, it is important that you keep your ostomy pouches, ostomy products, that you keep them with you. You don't put it in your checked luggage, because if you don't get your luggage, then you won't have any appliance with you. So it is very important that you keep them with you. And there's always the problem of the scissors, but what I recommend to my patient is to pre-cut, their own appliance, to prepare them so that they are ready to use when they need them. So they don't want to have to go through the security with scissors.
Very good.
And also, I want to say something else. You can ask the Canadian Association, or also there's an International Association of ET nurses. Let's say that a patient is traveling to Greece. Then we can find where there is an ET nurse in Greece, or where there is a store, a shop where they can buy any products should a problem happen.
Okay. So I have a question for you. Are ET nurses provincially funded? Are they accessible to everyone who needs them?
They are not. They are, most of the ET nurses work in big hospitals. In remote area, sometimes it's more difficult. But let's say in Canada, we may be about 500-600. So it is easy to find, a center where a facility, a hospital, where there will be an ET nurse. But if you live in the countryside, and you get operated in a small hospital, maybe there won't be an ET nurse. But I recommend all the patients to make sure before that they have access to an ET nurse, because it is important that they meet her before to discuss and to plan for the future, and it is among the rights of the person with an ostomy to have access to an ET nurse.
Right, and they are provincially funded through your provincial healthcare plan, just like any other medical
No,
source.
they are not. They are employed by hospitals.
Yes.
They are
So
just employed by hospital. They are an employee as any other employee.
yes, but your health care, if you go in with your health card and you're getting care,
It's okay.
they will be covered by your provincial insurance plan.
And some of them, they do private practice. Some of them.
They do, okay. In Canada, is that correct?
Yep.
Oh, great.
But not so many. I don't think so. Not so many.
Can you please explain quickly, if possible, how the stoma does not allow water to enter during a bath or shower?
Ah,
Is there a
okay.
valve system in place?
No, no, there's none, but it's because the pressure in the abdomen, in the bowel, is higher than the pressure, atmospheric pressure. If
Oh,
I want absolutely to bring water into my ostomy, then it is like when we do, how you call that, you know, when you enter ostomy, when you do, let me check for the word. Uh, sorry,
I wish I
sorry.
could help. I'm sorry, Louise.
I'm looking for, what is a fleet? A fleet is an irrigation.
Here, okay.
Okay, if I want an enema, you know,
Yes.
when you have an enema, if you apply pressure that is higher than the pressure in your abdomen. So this is why you can enter water in you. You have to apply some pressure
Okay.
against the pressure of your abdomen. So to get water into your ostomy, you must apply pressure. So if you are in your bath or swimming, the pressure is not big enough.
Okay. I have another question. Someone asked, is pregnancy with an ostomy still an option? And what special precautions should a person take if
Yeah,
pregnant?
so yes, it is a very good option. And the precaution would be to make sure that, you know, as the belly will expand, the ostomy will expand also. So it is important to take a good measurement of the ostomy and to cut bigger, you know, the opening of the skin barrier. So you do that during the pregnancy, and after, of course, it will come back as it was before. Just one thing that I would like to say for women with the pelvic pouch. They, you know, maybe they don't have any more the ileostomy, they choose to have a pelvic pouch. They can be pregnant, but usually, the surgeon will prefer that she does not give birth by naturally, you know, it will be a C-section.
Right. Well, I think that's all for this evening. Thank you so much, Louise, for your thoughtful responses. And I would like to thank all the participants for your wonderful questions. They were very well thought out and provided wonderful answers by Louise here. Please note that after this webinar, we will be sending you a short survey to get your feedback. And any additional suggestions you may have, please feel free to provide that information in the survey. We always appreciate our input from our participants. Also, in the coming week, we will send you a YouTube link to the recording of today's presentation. On behalf of Crohn's and Colitis Canada, thank you very much for your time tonight, and have a wonderful evening. Good night.
Bye-bye.
Bye-bye.